Hi everyone, our team is Balaji, Shrikant, and myself Soumya. Nibrat was our advisor. We are here to talk about one of the most life-threatening, life-changing, and major cause of mortality among women population, which is breast cancer. Breast cancer is an unsolved problem for a long time since last few centuries. 1 in 8 women in the US will develop breast cancer in her lifetime and 1 in 36 women die from breast cancer. Thousands of women under the age of 40 are diagnosed with breast cancer each year. Breast cancer starts in the breast as a group of cells that can invade surrounding tissue, and it can also spread to other parts of the body. Men can also get breast cancer, but it is very rare. Breast cancer is a life-changing diagnosis. Early detection helps control the spread of the disease and save lives. The positive is that there are 3.8 million breast cancer survivors in the US today. How do we detect breast cancer today? The most heard symptom of breast cancer is discovery of a lump in the breast. How do we differentiate between benign and malignant? Cells that is not a threat to invade other tissues is considered as benign or non-cancerous. When the cells are abnormal and can spread to other parts of the body, they are cancerous cells or malignant. To determine whether a tumor is benign or malignant, a healthcare provider can take a sample of the cells with a biopsy procedure. Then a pathologist, who is a doctor who specializes in examining tissues, runs these tests on the cells under a microscope. The pathologist is the first responsibility is to identify some of the findings on the tumor cells that may be used to aid in selecting therapy. Without the pathologist, a diagnosis of breast cancer cannot be made. Today's challenges with pathologists is our problem statement. Generally, pathologists are under serious time constraints. It's possible for some pathologists to be a little too lax, where true breast cancer are diagnosed as benign, and where other pathologists might be a little too strict, labeling benign as malignant. Breast cancer diagnosis and prediction is very complex and rarely clear-cut. The delay in pathologists to provide results due to multiple reasons is causing delay in identifying the cancer type. A shortage of experienced pathologists is also a concerning factor. The lack of extensive data set is another big challenge today. The accuracy of the results play a major role to identify the tumor type. Our team wanted to address the accuracy of prediction to help pathologists in identifying a tumor as benign or malignant using classification model and deep learning. We have also used semi-supervised GANs to generate synthetic data and labeled unlabeled data for classifying cancer grades where there is lack of data set for prediction.
A dataset used to build classification model to automate the histopathological images was built by Federal University of Paraná in collaboration with Pathological Anatomy and Cytopathology, which is located in Paraná, Brazil. The dataset composed of a total of 1995 images collected from 82 patients. All images are colored images. Each image is of size 460 by 700. Out of 1995 images, 1370 are malignant, 625 are benign images. From the pie chart, you can see this is imbalanced data set. To mitigate scarcity of pathologists and lack of labeled histopathological images, we explored three different approaches to automate the classification of histopathological images: transfer learning techniques, build CNN model from scratch, semi-supervised GANs. Let's briefly go through each approach. Transfer learning technique focuses on transferring knowledge gained during training of a machine learning model trained on one domain to a different but similar domain. The main purpose of this technique is to solve the issue of limited labeled data in the target domain. Like in medical domain, getting data is very tedious process. This technique also speeds up the time it takes to develop and train a model by reusing already trained model. The picture depicts how the transfer learning differs from traditional machine learning. We used various pre-trained models to train histopathological images. Table shows accuracy and other metrics from the pre-trained models. From the metrics, we can clearly see all pre-trained models are overfitting histopathological data. Since pre-trained models are overfitting histopathological image data, we analyzed architectures of pre-trained models, and with best features from pre-trained models, we created a CNN model. We used InceptionNet, ResNet, AlexNet network structures to create CNN. We took AlexNet as base architectures with all convolution layers, added an inception block and residual block at the end. CNN model created using AlexNet, InceptionNet, and ResNet, we achieved an accuracy rate of 96% for benign images and 97.81 for malignant images, with an FN score of 97 for the test data set. From the confusion matrix, we can see that misclassification rate is low compared to transfer learning models at 4% and 2.18% for benign and malignant images respectively. And final approach we did was to build a semi-supervised generative adversarial network. Main advantage of using semi-supervised GAN is to use both limited labeled data and abundant fake data generated by generator network. Here is the architecture of semi-supervised GAN. Semi-supervised GAN consists of discriminator and generator models that are trained in an adversarial manner using both limited and generated data. The discriminated model is designed as an unsupervised model stacked over supervised models sharing model parameters. Unsupervised discriminated model is to predict whether the image is real or fake image. Supervised discriminated model predicts whether the image is benign or malignant image. Generator network generates the images using latent vector, which are fed to discriminated network. With semi-supervised GAN, we achieved an accuracy around 85% for test data. Misclassification rates are too high compared to other approaches. I will let Srikanth take over rest of the presentation.
In this research, we mainly aim to check how semi-supervised GANs helps in improving detection of breast cancer and how classification accuracy behaves based on the limited label dataset that we have, and compare against the other transfer learning models and CNN models. All the transfer learning model accuracies gave accuracy between 85 to 90%, whereas mobile net and efficient net models gave less than 70%, which is due to the images it trained on before. On the other side, CNN model gave accuracy around 97%, but we had to give only the label dataset as input and the training time is higher. For semi-supervised scans, we got classification accuracy around 85%, which is less than CNN. But if we consider the data it took compared to CNN, it's very less. We provided 20% labeled data and rest of them is unlabeled data. Semi-supervised scan generated synthetic images and gave accuracy of around 85%, which we obtained in less than 15 epochs due to its potential to extract features from distribution of training data. We also observed the accuracy changes when there is a change in resolution of images. The main challenges we faced during the training process is vanishing gradient, where we saw some noisy images getting generated repeatedly. We rectified it by changing different activation functions and adjusting the learning rate. And also another challenge is the computing time to train the model. It took more than 24 hours to train the model. Even though there are several latest methods for cancer diagnosis in recent world, but still there is a room for improvement to automate and speed up the process of cancer detection process. It is exceedingly difficult to build a model for detection of cancer from histopathological data because of various constraints like time it takes to prepare a slide, resolution of images, or obtaining a good label dataset from pathologists. We believe the technique of semi-supervised scans can help in this area with better classification accuracies. The semi-supervised scan model can make use of both limited label images and abundant unlabeled images and provide better classification accuracies compared to other models. The results from our research should be used responsibly and should be used as a reference by pathologists until it is tuned for acceptable accuracies and not as a replacement of any existing diagnosis. As a future work, models should be trained on various histopathological datasets to improve the classification accuracy, and also one should actively work with pathologists in the initial period to check performance of model and tune it to reduce false positives or false negatives, which can be harmful to patient. Semi-supervised scans can also be applied to other kinds of medical images like X-rays, CT scans, and it can be extended to study other kinds of cancer detection as well. Thank you.